My name is Ellie Kirschenbaum, and I would like to introduce our next presenter, Aaron Beck. He is the Retail Pharmacy Coordinator for Nebraska Methodist Hospital, and he's here to talk to us a little bit more about the implementation and oversight for our Meds to Beds program.
Hello. So I'll just kind of briefly today just kind of go over what a Meds to Beds program is in case people aren't familiar with it, and then go over some of the reasons why there's a need for a Meds to Beds program in a hospital, and then give a little bit of just kind of oversight of how we implemented ours here at Methodist and some of our goals and objectives, and then some of our outcomes that we've currently had as well. So just to start, what is a Meds to Beds program? It's a pharmacy-led discharge service that provides patients with any new medications when they are discharged from the hospital. So they leave in hand with anything new that they are prescribed by the prescribers. They're filled at the hospital's pharmacy and then delivered to the room, either via our hospital does it by pharmacists, but some places do it by technicians or delivery people as well. And then with all these new medications, they are educated on them as well. So they do have time with a pharmacist to ask any questions, just for any understanding of the new medications that they'll be getting sent home with as well. So why is there a need for a Meds to Beds program? This is just a little bit of chart from a study where they look to see what the average time to fill a new medication after being discharged from the hospital. As you can see, about 40% of patients did go get their med the day of discharge, but then 1 to 2 days after discharge, 20% of patients got their meds filled, and then 18% of them did it 3 to 9 days after discharge, and then they found that 22% of patients didn't even go get their medications filled after they left. And then another study looked at all the electronic prescriptions that were sent from their organization over a 12-month period, and they used insurance claims to see whether the prescriptions actually were filled or not. This organization, they had a little over 82,000 prescriptions sent that were new for patients, and only 72% of those patients filled their medications, which means 28% also did not get their new meds filled after they were discharged from the hospital. Some of the reported barriers from the studies were that they didn't have transportation to the pharmacy. There's financial concerns, whether they either didn't have insurance or couldn't afford their copays, long wait times in pharmacies, and then difficulty understanding why they needed a new medication. And then another aspect to why a Meds to Beds program is needed is medication adherence. So just for a little bit of context, most studies refer to adherence to medication as taken at 80% or more of the time. So that means out of every month, they can miss 6 days worth of their meds and they would still be considered adherent by most studies. One found that 24 to 40% of people that were found to be non-adherent to their medications after being discharged from the hospital. And then another study found that 40 to 50% of patients that were prescribed meds for their chronic illnesses, so conditions that aren't necessarily new after hospital discharge, just chronic ones, were also not adherent to their meds. And they estimated that this could have caused about 125,000 avoidable deaths in a year, and then 100 billion annually in preventable healthcare costs. So as we can kind of see, the adherence portion is huge and can really affect the patients, whether they're readmitted to the hospital, and then obviously some avoidable deaths as well. And then they found that some of the factors that influenced adherence were the perceived risk of the disease, and then the perceived benefit of the medication, side effects or complexities due to changes in their regimens, limited health literacy, cost of medications, transportation issues, and then finally a lack of symptoms, and then whether they had depression or behavioral health conditions as well that prevented them from taking their medication. So Meds to Beds program can kind of focus on the first 3 of these. Obviously the last one, not as much so, but the first 3 is kind of the areas of where we can actually help and improve things. And then kind of lastly, a big reason why a Meds to Beds program is beneficial is it just helps reduce readmissions. 16 to 40% of hospital readmissions within a 30-day of being discharged can be attributed to medications. And this study that found this said that 40 to 70% of these were thought to be preventable. So most likely a non-adherent or misuse of their medications. And then they also found that patients that had low to intermediate adherence to their medications are 2.5 times more likely to be readmitted to the hospital within 30 days. So that's like if they're missing more than 6 doses or 6 days in a month's time, they're 2.5 times more likely to be readmitted to the hospital. So just kind of summarizing kind of why a meds to beds program can be beneficial is it ensures patients have their prescriptions filled at the time of discharge. So they're not having any issues getting to the pharmacy or paying for their medications. Promotes adherence through education. So being able to talk to a pharmacist one-on-one makes it so they can have time to ask any questions, have a better understanding of what their medications are doing and why they are necessary to be taken. And then can also help reduce readmission rates just by making sure these things are happening prior to the time of discharge. And then now I'll just kind of give a little bit of an overview of the Methodist Meds to Beds program at the main campus. Our objective was to support the hospital's initiative to reduce heart failure readmissions. And it was designed to target just the 9 South unit because at the time, 53% of the heart failure discharges patients were being discharged from that unit. So that's why we chose to use that unit as the focus target. And our goal was to reduce readmission rates by 10%. Our baseline, as you can see from 2020's data, was 21.2%. So reducing it by 10% would make the goal 19.8% by the end of 2023. And then our other goal was to increase patient experience from our 2022 baseline data of 64.16% and increase it to 68.8% or greater, which puts us at like the 90th percentile in that category. The way we kind of evaluate this is by using the HCAP surveys. There's a question on there. It's when I left the hospital, I clearly understood the purpose of taking my medication. So that's kind of how we're evaluating the patient experience portion of it. So the Meds to Beds workflow, it starts out with enrolling the patients into the program. So any patient admitted to 9 South, they're screened for heart failure. So there's a Cerner report that we're able to run that will give us diagnosis for patients. So if they have a heart failure diagnosis, they'll show up on that report. And then there's also consults that are sent to the pharmacy. So if a patient is admitted and the heart failure power plan is utilized, a consult's also sent to the pharmacy. So those are the 2 main ways that we were originally identifying patients if they had heart failure. And then if somehow somebody slipped through those 2 ways, we were also just doing a quick chart review on every patient just to see if they were being admitted for heart failures. Every once in a while, they were admitted for fluid overload, and then turns out that it was heart failure. So those would be the few patients that were kind of missed in the first run. And then we do an insurance verification just to make sure that we are contracted with their insurance. So we started the program up in the middle of March, didn't have all the insurance contracts in the beginning, but now we have the majority of all insurance contracts. So we're able to help most patients in that. And then finally, after we do all those things, we go to the patient's room, talk to them, make sure that they understand what the program is, some of the benefits of it, and then just ask if they would like to opt into the program at that time. So once they give us a yes or a no, we fill out a form in Cerner. So that allows us to track our acceptance rate. So the yeses will then populate a consult as well into the pharmacy or into the chart. So that way nurses can utilize that, knowing that if there's a meds to beds consult ordered, then they'll be receiving it at discharge. And if they decline service, then there's a reasoning that we can also check to say why they decline service. So I would say probably over 90% of patients are okay with it. There's a few that just prefer their home pharmacy. So that's the major reason why they would decline it. And then patient's pharmacy finally has changed also in the chart. So that way, when the prescribers do start putting in their discharge orders, they're automatically sent to the retail pharmacy there at Methodist. And then we kind of just wait at that point until the discharge orders get put in, and then the new prescriptions are sent to the pharmacy where they're filled. And then we deliver them up to the room via the pharmacist right now. In the future, we hope to have more staff, and then we'll be able to do it via a technician or like multiple pharmacists at a time. And then when we deliver the medications, the pharmacist is also counseling them. So that's the time that the patient has to ask any questions, or and we can just kind of explain the benefits of their medications and see if they have any questions. If there's any refills that are authorized by the prescriber, we do transfer those at the time of discharge, just because currently we're only a meds to beds pharmacy, so we don't do any like refills or anything like that. So they're transferred there, so that way the patient can just easily get them refilled once they do run out. And then these are current outcomes. I will say that this is just focusing on heart failure. We have expanded the program, so we don't focus just on heart failure right now. We're doing all of the 9th floor, so all cardiac patients at the moment. But our goal was to reduce the readmission rates from 21.2 down to 19.08 on the 9 South unit. And we currently have the data through Q3. And the readmission rate is down to 15.32. So we're so far succeeding in that. We do expect it probably to go up slightly just in Q4, just because of the time of year. Patients are traveling and maybe not eating as well as they should because of the holidays. So historically, it goes up slightly. And then for the patient experience portion, our goal was to increase it from 64.16 to 68.8. Through Q3, we're currently at 67.01, so we're in the right direction. So hopefully with the Q4 data, we'll be able to reach that goal as well. And then some of our metrics, like I said earlier, we started the program in about middle of March of 2023, and we've currently through December filled 779 prescriptions for patients and a total of 304 patients. Both heart failure and just cardiac patients. And then another really nice thing at Methodist is we're able to use the foundation to assist with medication costs for some patients if they're either uninsured or underinsured. So with that assistance, we've filled 125 prescriptions for 23 patients, which has saved the patients well over $10,000. So that's a really nice benefit that we do have, that we are able to help those patients. Because a lot of those would be the patients that go to the pharmacy, can't afford their meds, and then end up just not getting them filled, and then would be readmitted to the hospital most likely. So kind of just in conclusion, what the kind of benefits of a meds to beds program are. Main one is to increase adherence by making sure patients have their medications in hand at the time of discharge. And we're able to give time to educate them, just so they have understanding of what their new meds are, how they work, any side effects that they might encounter, and then also have the ability just to answer any questions. And then we enhance transitions of care just by making sure that their prescriptions are covered at the time of discharge is one of the big reasons. Making sure that their insurance, their copays are affordable. And if not, we can have the time to get those things clarified or changed prior to discharge. So instead of the patient showing up to the pharmacy and then them having to call the prescriber, and then a day or two goes by before they get back to it, we're able to kind of have all that resolved by the time the patient actually leaves. And then lastly, just convenience. It's nice for a patient when they're leaving the hospital not to have to stop and wait in the pharmacy. They're able to just go straight home and continue recovering. And that's kind of the Meds to Beds program at Methodist. Is there any questions? Yeah.
With home health agencies, because when patients get home, they're overwhelmed with the medications, and when did they get, how they can observe the coordination.
Not from from the pharmacy standpoint, there's not, at least not at the moment. usually just kind of go over their meds with them, and they do have a list in their chart that I kind of try to review with them too, just in case they do have questions on how to take stuff, and we just tell them to reference that at the moment. But yeah, no coordination with home health care at the moment.
Do you guys just bill to insurance directly then? Because like normally when you go to the pharmacy, you have to pay with whatever. So you just do it through their insurance?
Yep, we bill the insurance, and then we have like a cash bag credit card reader. So if they do have co-pays, we do take payment before they leave as well too. So sometimes patients are told to like send all their stuff home. So when those situations happen, we usually just wait until their family comes to pick them up, and then we take them up and collect payment there. If they have co-pays, sometimes they don't.
Is the cost similar or is it more expensive if they get them there then?
Should be the same. Yeah. When you're billing insurance, most of the time it's like a straight copay, no matter where you go and fill them. So it's like a contracted rate. So it would be the same as if they filled it at another pharmacy. The only caveat is sometimes mail orders are a little bit cheaper, but when they're getting discharged from the hospital, they would have to go to a retail pharmacy either way to get those new meds.
What about those heart failure patients that have been readmitted? It's not a new diagnosis, so perhaps they were already on that med prior to, so it's not a new med. So is there any opportunity for you to do that counseling or to have the meds to beds program for those patients, or is it just newly diagnosed?
There's always I could always go and answer any questions if they have questions in that. We also, I think I heard them talking earlier, do the heart chat, and there's a pharmacy portion every week as well. So that's, patients are always encouraged to go to that, so that way they can ask questions. Most patients, I would say, if they get readmitted, most likely there's a medication change. So that does give us an opportunity to fill a new med for them and kind of talk to them about their others as well. And if they're out of something, we can always do a refill for them too, if the prescriber sends something in. So.
Question. Sorry.
You mentioned contracting with insurance companies. Does Medicaid cover this?
Yeah, yep. So it's just like any normal pharmacy that they would go to. Like we have a contract with Nebraska Medicaid, so we can fill any prescriptions for patients with Medicaid as well. We currently don't have one with Iowa Medicaid, so that's one that we don't have. But yeah, Medicaid patients are eligible for the service and everything. It's no extra cost for the program. It's just filling the meds, just like any retail pharmacy.
Great presentation. Thanks, Erin. 2 questions for you. Number 1, on the readmission rates that it dropped down to 15%. Is that just at Methodist Hospital, or are you looking at claims for all hospitals?
That's just at Methodist.
Okay.
Yep. That's just our data, because our heart failure patients are kind of like our pilot group for the Meds to Beds program. So that's just ours.
Okay, perfect. And then second question, knowing that the success for cardiology, have you thought about what your next targeted disease states might be for expansion?
Instead of disease state targeting, we're just going to go by floor, just because disease state is hard, just because patients can kind of get admitted everywhere. So then you're having to train lots of staff, just making sure nursing knows about the program and stuff is a hard to do sometimes. So if we do it by floor, it makes it easier, because then you can just kind of focus on one unit at a time, make sure everybody's trained, understands what Meds to Beds is. So that way there's no patients leaving the hospital without their meds just because they didn't realize and things like that. So our current plan is just to go kind of floor or unit by unit as we expand the service.
Do you have a next target floor? That's
I think it's 8 South, but we need to get staff first. Currently, it's just me running around every day.
What's your average turnaround time? Does this delay discharge from when the doctor writes the order to when the patient's out the door?
It could a little bit, just because there's one extra step after the discharge orders are put in. But usually I can have prescriptions up within a 30 minutes from receiving them. So sometimes it only takes a couple minutes because a prescriber sent the orders in the morning, and then the discharge order didn't get put in until the afternoon. So everything was kind of ready. But if it all gets kind of put in all at the same time, 30 to 45 minutes is probably the average of getting things up to the room.
Generally, is it a 30-day supply?
Yeah, generally it's 30 days. If the prescribers send for a 90-day prescription, I'll always try sending it through for that. Some of the insurances with new meds, they limit it to 30 days just in case doses get changed or things get discontinued. They don't want to, insurance doesn't want to pay for 90 days if they're not going to use it. So yeah, usually 30 days is what we do.
I just have a quick curiosity question. Are you there just Monday through Friday then, or what are your hours of operation you're doing currently, and what's the plan long term?
Yeah, right now it's just Monday through Friday just because it's me by myself, and it's 8 to 4:30. Yep. So just Monday through Friday during the day. As we get more staff, we do want to expand into being open a little bit later to catch some of those like night discharges. And then eventually, I think too, we'll probably do some weekends. I think current goal is just to try to get the whole hospital kind of in the program first, like a Monday through Friday, because that's when most of the discharges occur is during the day, Monday through Friday. But then eventually we will expand our hours.
I can just speak from the ninth floor experience. I mean, if we know somebody's going to be using meds to beds and they're going home on the weekend, we try to get all their meds in on Friday so that he can come and talk to them. And that doesn't work then if somebody changes a med, but so far that hasn't happened too much. But we do try to plan ahead so that that can be taken care of. And the same is if the foundation is helping cover things, we try to get that taken care of before the weekend as well. Any other questions?
Our next speaker is Hillary Knitch. She's a pharmacy resident at Nebraska Methodist Health System. She's going to be speaking with us about increased use of diabetic medications
Dance party.
in cardiovascular patients, what you need to know about safety, side effects, and indications for use.
All right, well, thank you all for coming here and for having me here. It's an honor to talk at this cardiovascular symposium. So I will be talking about the increased use of diabetic medications in our cardiovascular patients and what we need to know about safety, side effects, and our indications for use. So some of the objectives I'll cover throughout this presentation. So I'll describe indications of our diabetic medications and their use in our cardiovascular patients, evaluate the benefits and risk of our SGLT2 inhibitors and our GLP-1 receptor agonists in our heart failure patients. And then we'll kind of walk through and construct a treatment plan to optimize morbidity and mortality benefits in our patients with heart failure as well. This is just a glossary of terms, abbreviations, what they stand for reference throughout this presentation. So we'll touch base on the first objective. So I'll describe indications for diabetic medications and their use in our cardiovascular patients. So before we really dive into the medications, let's just kind of talk about the cardio-renal metabolic connection here. So we know obviously all of these medications have an indication for diabetes. And so our patients who have diabetes have a metabolic dysfunction. And so this leads to hyperglycemia, oxidative stress, and endothelial dysfunction, which can then lead to impaired renal function. And then with impaired renal function, we have sodium and water retention, RAS overactivation, uremic toxins, and then that can lead to chronic inflammation, which can cause cardiovascular dysfunction. And then with cardio dysfunction, it can further cause atherosclerosis, myocardial dysfunction, and heart failure. And so you can see here how the SGLT2 inhibitors, GLP-1 receptor agonists, and the GIP-GLP-1 receptor agonists kind of target all these core areas and provide benefits in these areas. So what are SGLT2 inhibitors? So the sodium glucose cotransporter 2, SGLT2 for short, is found in the proximal tubule of our kidneys. And so people without diabetes, the SGLT2 is responsible for greater than 90% of our glucose reabsorption. So the SGLT2 inhibitors are small molecules that decrease the reabsorption of glucose in the kidneys. So increases glucose excretion and then decreases blood glucose. And then our newest agent as of last May, I believe, it's actually an SGLT1 and 2 inhibitor. It's sotagliflozin and PEFA is the brand name. And so with that SGLT1 additional benefit, it inhibits intestinal absorption of glucose and sodium as well. And here are all the labeled indications. So we know they're all have a labeled indication for type 2 diabetes. We see dapagliflozin and Farxiga is the brand name, and empagliflozin, Jardiance is the brand name, labeled indication for chronic kidney disease. And then with the red highlighted box there, you can see dapagliflozin, empagliflozin, sotagliflozin all have labeled indications for heart failure. And then the newest agent actually has a labeled indication for cardiovascular risk reduction. And here's all the dosing for these agents. And so only the ones that actually have labeled indications for heart failure. So that would be the dapagliflozin, empagliflozin, sotagliflozin. So with empagliflozin and dapagliflozin, it would be 10 milligrams daily. That would be the initial starting dose. And then for the newest agent, it would be 200 milligrams daily. And just important to note with the newest agent that you would want to separate that medication from the first meal of the day. So separating it from food. And then just some important considerations with these agents. So with dapagliflozin and empagliflozin, you're not going to want to initiate these agents if the patient has a GFR less than 25 in dapagliflozin or a GFR less than 20 in empagliflozin. You would not want to initiate these agents. However, it's important to note if the patient was already on these medications, you can continue them. You don't have to discontinue these agents. And then with sotagliflozin, it hasn't been studied in patients with a GFR less than 25. So then what are our GLP-1 receptor agonists? So these are agonists of the glucagon-like peptide 1, GLP-1 for short, which is a receptor that is expressed in various tissues. And so these stimulate insulin release and then decrease glucagon release. And then additionally, they slow gastric emptying and inhibit inappropriate post-meal glucagon release and reduce food intake. And so you can see with the little picture up there, the red highlighted box, the cardiovascular benefits that they provide. So they increase myocardial contractility and increase ischemic preconditioning, and then they decrease inflammation and arterial stiffness as well. And then here are the labeled indications for the GLP-1 receptor agonists. So we know, again, all have labeled indications for diabetes, and then a couple of them have labeled indication for chronic weight management. So currently there's no labeled indication for cardiovascular use. However, that doesn't mean that they don't provide cardiovascular benefits. And here's all the dosing here for these agents. So our more popular ones, so dulaglutide, Trulicity, and then semaglutide, Ozempic. So these are, so all of them are sub-Q injections, but those ones are once weekly injectable medications. And just important to note, we want to consider renal function as well. With the more popular agents though, we don't have to do any renal adjustments with those more popular agents, but with the other ones, exenatide, liraglutide, or liraglutide, you don't have to either, but the other ones, just important to consider, you would not want to use them if the patient had a creatinine clearance below a certain level, or if they had a GFR below a certain level as well. But the newer and more popular agents, you do not have to do any renal adjustments with those medications. So then we'll move on to what are our GIP and GLP-1 receptor agonists. So these are dual agonists that selectively bind to both the glucose-dependent insulinotropic polypeptides, so the GIP, and the GLP-1 receptors. And so the GIP component promotes energy storage and enhances bone formation. So you can see from that little diagram there how the dual receptor agonists and their combined effects provide greater benefits. And so the only FDA-approved dual dual GIP/GLP-1 receptor agonist is tirzepatide, otherwise known as Mounjaro. And so you can see labeled indication diabetes. Zepbound's the brand name for chronic weight management. And again, no cardiovascular indications for these medications, but doesn't mean they don't provide cardiovascular benefits. And here's the dosing for those agents. Just important to know, no renal dosing for these as well. So now we'll kind of move into the second objective. So we're going to evaluate the benefits and the risk of our SGLT2 inhibitors and our GLP-1 receptor agonists in our cardiovascular patients. So this is just kind of a nice little chart here. So we'll be defining high-risk patients for cardiorenal risk reduction. So we can see here are patients who have established ASCVD, so patients who've had previous MI, stroke, and are patients who have positive indicators for high risk. So patients greater than or equal to the age of 55 who have 2 or more additional risk factors, so hypertension, diabetes, smoking, dyslipidemia. Those patients, they benefit from GLP-1 receptor agonists and SGLT2 inhibitors. So those agents have proven cardiovascular disease benefits. And then our heart failure patients, we know that the SGLT2 inhibitors have proven heart failure benefits. And this is just a further elaboration of the benefits of our SGLT2 inhibitors and GLP-1 receptor agonists. So we can see here the cardiovascular effects. So they both provide MACE effects, and MACE is short for major adverse cardiovascular events. So they provide benefits against stroke, against MI, against heart failure, hospitalization, and even death. And then we see here that the SGLT2 inhibitors provide benefit in our heart failure patients. And then it's neutral with the GLP-1 receptor agonists, and then the dual agonists are still under investigation on their cardiovascular benefits. And then this is just a further elaboration of all of the potential mechanisms of how the SGLT2 inhibitors improve cardiac function. So you have the stimulation of natriuresis, stimulation of osmotic diuresis, reduction in left ventricular mass, and just all the many benefits that the SGLT2s inhibitors provide for our cardiovascular patients. So essentially, just important to know that the SGLT2 inhibitors are way more than just glycemic lowering agents. So empagliflozin, so shown to reduce mortality in type 2 diabetes and establish cardiovascular disease, reduce the risk of cardiovascular death and hospitalization for heart failure, regardless of ejection fraction, regardless if the patient has type 2 diabetes. And this is the same for dapagliflozin as well. And then sotagliflozin reduces risk of cardiovascular death, hospitalization for heart failure, and urgent heart failure visits in our adults with heart failure or type 2 diabetes, CKD, and other cardiovascular disease risk factors as well. And so the next few slides will just be some of the studies that the SGLT2 inhibitors did to prove their benefits. So this first study is the DELIVER study. And so this was with Farxiga in our patients with heart failure with preserved ejection fraction. So you can see that there was an 18% relative risk reduction in the composite endpoint of cardiovascular death, hospitalization for heart failure, or urgent heart failure visit. So 18% of the risk for cardiovascular death, hospitalization for heart failure, urgent heart failure visit was removed in our patients with heart failure with preserved ejection fraction taking Farxiga. And then the DAPA heart failure study. So this was with our heart failure with reduced ejection fraction. So it showed a further decrease of 26% with their relative risk reduction in those same primary composite endpoints. And then this was the Jardiance trial. So the Jardiance demonstrated a statistically significant reduction in cardiovascular death and hospitalization and heart failure, regardless of left ventricular ejection fraction. So you can see in the yellow, it's the preserved ejection fraction. So it showed a 21% relative risk reduction and cardiovascular death and heart failure hospitalizations. And then the green is the reduced ejection fraction, so a further decrease of 25% in our heart failure with reduced ejection fraction patients taking Jardians. And then this is the newest SGLT2 and 1 inhibitor. So INPEFA showed a 33% relative risk reduction in those same primary and composite endpoints. And so just some considerations with our SGLT2 inhibitors. So you may see a transient acute reduction in the patient's GFR. However, this is followed with a progressive recovery in their renal function. You may see up to 30 to 40% reduction in albuminuria. And then just important to assess kidney function at baseline and periodically thereafter in these patients. And then using caution when starting up any ACE inhibitors or ARBs, any dramatic fluctuations in the hemodynamics of patients could potentiate an AKI. So just use caution when starting up those agents at the same time or increasing and starting at SGLT2 at the same time. Consider decreasing diuretic doses since SGLT2 inhibitors also cause like a diuretic effect as well. And then weight loss and glucose lowering effects are attenuated in CKD, but the cardiovascular and kidney outcomes are consistent in our patients with or without CKD. And so now I just kind of have like a quick response question here. So which side effect do you guys think is the most common in our SGLT2 inhibitor monotherapy use? And so we have our options. So we have hypoglycemia, nasal discharge, nausea, or urinary tract infection. I'll give you guys a couple seconds to decide what you would pick as the answer. All right. So if you picked urinary tract infection, you would be right. So the most common side effects of the SGLT2 inhibitors, so urinary tract infection, genital urinary fungal infections. You may also see weight loss, rash, increased urine output, dehydration, and nasopharyngitis as well. And then some of the monitoring parameters with these agents. So we're going to want to monitor blood pressure, serum creatinine, BUN. And then you will want to monitor blood glucose and A1C if the patient is a type 2 diabetic and using other agents that cause a reduction in hypoglycemia. If the patient is just using the SGLT2 inhibitor for heart failure, you do not have to do regular blood glucose checks in these patients. And then additional monitoring parameter, monitoring the serum cholesterol profile as well in these patients. Then just some tips for use. Make sure our patients are educated on proper genital urinary hygiene, minimizing highly acidic foods, importance of staying hydrated, minimizing caffeinated beverages, dehydrating foods and beverages. Make sure that they're aware that these agents may increase the frequency of urination, and make sure they're educated on the signs and symptoms of DKA, which I'll talk a little bit more on the next slide here. And then ultimately using caution in patients on volume depleting medications such as diuretics. So SGLT2 inhibitors and euglycemic diabetic ketoacidosis or DKA. So what are some of the risk factors for DKA, euglycemic DKA? So our patients who are acutely ill, patients have a reduced caloric intake, and then one of our most common ones is our surgery patients. So what does euglycemic DKA present as? So nausea, vomiting, abdominal pain, shortness of breath, general malaise. And just important to note that hyperglycemia may not always be present in these patients. And then some of the things that we do to, as a risk mitigation for euglycemic DKA, again, educating patients on signs and symptoms and what to look out for. And then we make sure that these agents are held, a majority of them 3 days prior to surgery. And then we only resume them at Methodist if they have a labeled indication for heart failure. So we do not resume these agents in just our diabetic patients. And then just some considerations with our GLP-1 receptor agonists. So these are absolutely contraindicated in our patients who have medullary thyroid carcinoma. We would never start these agents on these patients. If they have a history or if they have a familial history, we would stay away from these as well. And then just one of the newer, you may have seen in the news, there's been reports of GLP-1 receptor agonists may be causing suicidal ideations. And the FDA has done a preliminary evaluation of these agents, and they have found no indication that they cause suicidal thoughts or actions, but they are doing further investigation of these agents as well. So you may get some concerns from some patients. Some additional adverse reaction considerations. So if the patient has a history of pancreatitis, gallbladder disease, and biliary tract disease, these may not be the best agents for those patients. Again, contraindicated in our medullary thyroid carcinoma patients. Considerations of diabetic retinopathy. So this is mainly observed in our patients with pre-existing diabetic retinopathy, and then primarily attributable to the magnitude and the rapidity of how fast the A1C is reduced, and could further exacerbate diabetic retinopathy. And then just monitoring for hypersensitivity reactions, and then acute kidney injury. So pre-renal AKI may occur due to dehydration and volume contraction, which is secondary to the most common side effect of the GLP-1 receptor agonist, which is GI symptoms. So most common side effect, again, GI symptoms, nausea, vomiting, diarrhea, abdominal pain. You may see some fatigue, headache, nasopharyngitis as well. Some monitoring parameters, so blood glucose, A1C, again, if they're type 2 diabetic, and using other hypoglycemic agents, and then heart rate if the patient's on semaglutide. Important education points that the patients should be aware of. Make sure that they're storing this medication in their refrigerator prior to use, that they're injecting this medication into the fatty part of their skin. So most common area would be the belly. They can do the top of the thigh, the upper arm, and just make sure that they're rotating sites to help prevent any bruising. And then that they're taking it on the same day or using it the same day every week. And then just really important that they're aware that it is common to see GI symptoms, so diarrhea, upset stomach. But if it gets worse and doesn't seem to be going away, that's when they're going to want to contact their provider to make sure that they're aware. And so the last objective, so we'll construct a treatment plan to optimize morbidity and mortality benefits in our heart failure patients. So just a brief review here. So stage A is our patients who are at risk of heart failure. So patients with hypertension, cardiovascular disease, diabetes, obesity, etc. And then our stage C is where the patient already has symptomatic heart failure. So recommendations for patients who are at risk of heart failure. So our stage A patients, it's actually recommended that our patients with type 2 diabetes and cardiovascular disease, or patients who are at high risk for cardiovascular disease, so hypertension, obesity, family history of cardiomyopathy, SGLT2 inhibitor therapy is recommended as primary prevention. And then again here, so stage C are symptomatic heart failure. So reduced ejection fraction, SGLT2 inhibitor therapy is recommended. Our patients with mildly reduced ejection fraction, SGLT2 inhibitor therapy is recommended. And then this just further reiterates, so SGLT2 inhibitor therapy has shown morbidity and mortality benefits regardless if the patient has type 2 diabetes and regardless of ejection fraction. And so this here is just a slide of the benefits of evidence-based therapies for patients with heart failure with reduced ejection fraction. So you can see here the red highlighted box there. So you see at the 12-month mark, the number needed to treat was 63, and then the number needed to treat at 36 months actually decreased, which is good. And it was at 22. So for every 22 patients treated with an SGLT2 inhibitor, this prevented one all-cause mortality event. So this prevented one heart failure mortality. And then again, here's stage C, preserved ejection fraction, SGLT2 inhibitor therapy is recommended. And then one of the newer trials here, so this was last summer, STEP, heart failure with preserved ejection fraction. So semaglutide provided findings towards evidence-based therapy for people with obesity who are suffering from heart failure with preserved ejection fraction. So might be something to be on the lookout here in our near future, seeing GLP-1 receptor agonists having an indication for heart failure. And so just some of our key takeaways from this presentation. So just knowing that our SGLT2 inhibitors and our GLP-1 receptor agonists are way more than blood-lowering agents. They have proven cardiovascular benefits. And then our SGLT2 inhibitor therapies recommended in our patients at risk of heart failure with type 2 diabetes and cardiovascular disease, or at high risk for cardiovascular disease. So use as primary prevention in those patients. And then those agents decreased heart failure hospitalizations and cardiovascular mortality. And then our SGLT2 inhibitor therapy is recommended for stage C heart failure, regardless of ejection fraction, and regardless if the patient has type 2 diabetes or not. And that concludes my presentation. Does anyone have any questions at all?
On the SGLT2 with diabetics, you mentioned lowering or considering not putting them on an ACE or an ARB. Will they be just as renal protective with just the SGLT2 without adding an ACE or ARB in the diabetic patients?
I think it was more about not doing like such dramatic changes all at once. So they're perfectly fine being on both of those same agents, but maybe not increasing an ACE if they're already on it and adding an SGLT2 at the same time, or just taking extra precaution and monitoring to ensure the patient doesn't have an AKI. Right.
I actually have two questions. One of them, you said about monitoring renal function. Do you know what the guidelines are on for when they should be followed up for checking their bun and creatinine, those things when initiating? Because you said before initiation, then afterwards. Do you know how soon that is?
I think normally we check up like how they're handling the medication. So it's like 4 weeks is our time frame. I'm not entirely sure with labs like when you would check like renal function, but I know from like a pharmacist standpoint, we always follow up within 4 weeks just to see like how they're tolerating the medication.
Okay, and then my other question was on one of your slides with the GLP-1 receptor agonist therapies to monitor heart rate with the semaglutide.
Yeah,
Do you know what you're looking for specifically with that?
it can just cause some tachycardia. So yeah, just
Okay. Thank you.
You're welcome.
I just wonder with these drugs, insurance coverage and Medicare and how they're, what the cost is, and is it covered for a lot of those people?
I know it's becoming easier to have them covered. And I also know a lot of manufacturers have like coupons that you can use through them as well. But I think they're still still pricey, but they're becoming easier to be covered under insurance and easier like to have the cost reduced with the manufacturer coupons as well.
I just have a comment on the insurance one.
Oh. Yes, please do.
Thank you. So on that insurance one, what we're seeing from a lot of our Medicare Advantage and some of our commercial payers is they're making it actually more stringent to get some of these because of the overuse for more of the chronic obesity treatments. So now they're having to have a diabetes or it's going to require a different prior auth or the payment won't be covered. So it'd be an out-of-pocket expense. So we're hoping to see more of that coverage when we're looking at things like heart failure and the cardioprotective pieces there. But from a HEDIS perspective, from quality, because this wasn't completely covered, HEDIS is about 2 years behind, I would say. So they're still pulling patients into denominators based on just diabetes, not necessarily looking at the cardioprotective pieces. But there's a lot of pieces happening with legislation and HEDIS coming together from a quality perspective there.
Any other questions? And all my many references.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.